and then we'll get going. Welcome, ladies and gentlemen, to the October board of the George Eliot. We have apologies from Glynis, Washington, and we at the moment have apologies from David Eltringham, who has gone to have his photograph taken with the High Sheriff, who, bless her, is doing a tour around the county on a bike. So we wish her well on that journey. So David will be returning later. So we are quorate. Any new declarations of interest? Please raise a digital hand if you have a new declaration of interest. Rebecca?
Thanks, Russell. Just to declare that my daughter's partner works for the Audit and Assurance Portfolio Division at Deloitte, who are our new appointed external auditors. I've given details to Sarah. Thank you.
Thank you very much. And on that regard, my son now is employed by Deloitte in some far-flung corner, so that's a declaration of interest given they're an auditor of ours as well. So the last set of minutes, Julie, thank you very much for chairing the last board for me. The last set of minutes on the 7th of September, was everyone happy with the accuracy of those minutes? Please raise a digital hand if you want any adjustments. Okay, I can't see any digital hands, so I'll take those as accurate and duly sign on behalf of the board. And therefore, in terms of action points arising on page 21 of the pack, the first was regarding the CQC Escalation Notice. Glenn, just verbally brief us on this as well, because...
Yeah, the CQC are still following their normal way of working, which means they have to carry out an inspection in order to update a notice. They never actually withdraw them. It's just a new inspection that replaces them. So they're very aware of the progress we've made. They're aware we're frustrated and would like them to come back, but they are targeting their inspections on places that they feel they need to go to, and we're not one of them. Okay,
well, that last point, I think, is at one level assuring to us anyway, albeit frustrating. The next is the position regarding 38-day transfer performance. That's going to be included in next month's integrated performance report, so thank you for that, Stephen. Look forward to seeing that in November. Then the weekend mortality RAG rating, that's been complete. Thank you, Catherine. Really great progress on our mortality generally. CQC progress and preparedness update being removed in the board reporting matrix. Thank you for that, Daljit and Ness. And then the CQC indicators regarding nursing and midwifery staffing report. That's been adjusted. Thank you, Daljit. It is worth just saying that all maternity services, I think, around the country are facing challenges in terms of recruitment, and we are no different in that regard from others. Then on the registered nurse and registered midwife data to be recorded separately, that's been done. Thank you, Daljit. And then the assurance from the maternity deep dive in sickness to be captured in the next safe nursing and midwifery report, that's been done as well, and we'll come back to that. Thank you, Daljit. Stephen, to ensure the winter plan, setting out a holistic overview on the trust plan to tackle winter pressures. That's on the agenda, and we had another discussion this morning on our progress on electives, which in context is going well. Not as high as we would like, but in context, I think is a relatively pleasing picture. And then finally, a report to be brought back to a future board on work being done by our friends at UHCW to address delays in shared service referrals. That's on the agenda, so we'll come back to that. Are there any action points I've missed? Could you please raise a digital hand if you think there are? Okie dokie, we'll move on then. So Glenn, over to you. How are you seeing things, Glenn?
Thank you. Yeah, quite a bit to see at the moment, and I'll just go through the highlights in the report. So I gave a verbal update about the NHS funding settlement last time, so there's some words in the report now, £36 billion over the next 3 years, which is obviously very much welcome. We can't magic up lots of staff to spend all of that immediately, but we obviously it gives us an opportunity to do so over a longer period. Not all the strings have been fully attached to that funding allocation yet. What we do know is that we will be expected to remove all 104-week waits or above by the time we get to the end of March. And we will, as the report says, see an elective care strategy in November that will set out what will happen over the next 3 years. And that strategy is really key to ensuring that we improve the waiting times for patients. So very much looking forward to that, and really pleased to see Sir Jim Mackey's been leading on that on behalf of the NHS. And the interesting stat there that £1 in every 3 of public expenditure is now with the NHS, and it just kind of raised the profile of the expectation of this this taxation rise, which is an unusual one for the present government. We will be expected to deliver. So we will be looking carefully at that elective care strategy. And also, as the report goes on to say, the way we manage urgent care over this winter. We talked about this in workshop session this morning, and I think I described everything that can cause us pressure over winter. The dial will be turned up on this year, including some of the workforce challenges, but also concerns around flu and ongoing COVID, but obviously the need to maintain elective activity, which sometimes in previous winters has been paused. There is an expectation that we protect that elective capacity. And I, for one, am really keen to ensure that we do, because actually there's nothing worse for urgent care than delivering urgent care in the wrong bed. So it's safer for our patients to manage urgent care in that really good work that George Elliott and all the great work we've done. I then have to talk about the departure of Stephen, our Director of Operations, and congratulations to Stephen for the job that he's moving to as a Chief Exec. Very lonely job, Stephen, Chief Execs, but you will, I'm sure, be a great one. But it's definitely a loss to us to see you moving on. So we're going out to recruit the next Stephen, and hopefully they'll be with us soon. Stephen, in the meantime, is also helping with a review of the operational structure at Swift, as the Director of Operations there is moved into a system role. There's an update on the board effectiveness review. There's then a focus on the directorate update of surgery, who are clearly doing a lot of that work that I've described. If you look at our performance data later on 104 weeks and 52 weeks, we're in a really good place compared to the rest of the NHS. And then a couple of detailed bits around our medical examiner service and the great work that they do. This is a new requirement that came into place recently, and I know that there was a visit of Rebecca and David to our bereavement team and saw some of the work that the medical examiners are doing only a few days ago. And then also staff engagement. So that visit was part of a series of visits which is set out here, where execs and non-execs will, following all appropriate infection prevention and control guidance, be spending more time in the departments now that we're able to ease ourselves out of that a little bit more. Happy to take any questions. You're muted, Chairman.
Thank you, Glenn. Your connection's a little bit variable, so if you need to go off screen, we will understand that. So questions and perspectives to Glenn. Julie?
Thanks, Glenn. I just wanted to say, really, because there's, we've made the link a number of times between elective urgent care, winter plan, the pressures on staff, and we talked a lot about this today, and still concerned that the funding settlement isn't going to deal with the funding crisis in care. And we need to make that there is an absolutely explicit link between the two. But what we heard today at workshop, and just wanted to reiterate, was that what we are doing, despite of that funding, to work more closely with our partners in social care through winter to ensure that people are treated in the right place, but actually to help with flow and discharge.
Absolutely right. I mean, we're all one big team between health and social care. We talked this morning about that place-based partnership arrangement, and certainly we ought to be doing whatever we can to help to address some of those workforce challenges, because there's a real opportunity still for us to left shift activity out of the hospital into the community if we can get the workforce right.
Yeah, Glenn's interesting stat that 1/3 of all tax revenues now effectively going to the NHS and social care. Just to put that into some context, in the year that I was born, and this will amaze a number of you, in 1960, it was below 1 in 10. So, you know, as a society, we're putting more and more money into the important work of looking after the health of the nation, but the focus, and Julie and all board members know this, our focus as a board is on driving towards better outcomes at better value, and the work that's going on with all of our partners within the system is designed to do that. So thank you, Julie. Any other questions to Glenn? Okay, I can't see any digital hands raised, so thank you, Glenn. And so we'll move on then to the mid-year review of trust objectives. Glenn, are you going to lead on this?
Yes, I am. So Jenny's done all the work on this, I might add, but it's that point in the year where we just take stock of our progress against the objectives that we set for the year, and board members were obviously very close to the work involved in setting these. Also, there's some group-wide opportunities for collaboration in here. We've got a pre-board meeting next week, I think, so we will be taking stock of some of those there as well. I won't go through the entire report. It's encouraging to see a great deal of progress being made despite all of the other pressures. The extract actually under the executive summary sets out some of the things, some of the bigger things that we've been able to move on as an organisation. Obviously, we've got the second half of the year to come. It tends to be a slightly tricky second half of the year, so it's good to see the progress we've made, but I'm sure progress will continue on all of those fronts throughout. I or Jenny or the lead directors are happy to take any questions on anything in the report.
Thank you, Glenn. So this is just a simple mid-year update for us. Any questions to Glenn or Jenny or colleagues? Please raise a digital hand. And Rebecca?
Thanks, Chair. I'd just like to commend, actually, in particularly the foresight of developing voluntary services to work with us in our trust, and how that helps us at Place to work with all agencies across the patch for the benefit of patients and communities. Thank you.
No, I'd like to reinforce that point, Rebecca. Even the informal feedback I get from voluntary organisations that work with the George Eliot is almost universally positive. So I think we have much to be proud of in the way we work with partners. Any other questions to Glenn or Jenny? Okay, so we'll move on then to the important winter plans. Stephen?
Yeah, Craig Simpson's joined us, who's the General Manager for Medicine, but has been leading on this piece of work for us as the Trust. So I'll take you through the report briefly, take it as read, and then Craig's around as well. First thing is probably to thank Craig and particularly Winston and his team for the work that they've done around this. And I've put some performance figures in, and we talk about that quite regularly. But I think it's really important for board and people watching to get some of the context. So we talked around putting more bedded capacity on the site, and we did do that with the Captain Tom Moore unit. I think that's put us in a really good position to maintain the two aims that we identify in the report. One is around urgent care and flow, but the other one is that elective, carrying on with that elective work and trying to tackle that backlog that's been built up. And probably the 2 winters previous to COVID, we've never quite been able to do that because of the urgent care pressures, but I think we're in a much better shape to do that this time. And certainly the work that we've been doing with the previous winter plans and through on a lot of the work on flow has put us in a good position in terms of, for Medicine, they're actually under their bed base at the minute, which I think is really important. So if we took out the COVID restrictions and the way that we've currently had to construct the site, Medicine would actually be operating well within its bed base, and surgery would be close to it. So in terms of having the right number of beds on the deck, I think we've done a pretty good job of trying to kind of do the demand and capacity around that and get us to that point. So I've touched on a bit on the performance, and the main things to draw out is we've done a capacity gap, so we look around 25 bed deficit on what we think might happen and running the current restrictions on the site. So if any of that was to change, we're going to keep modelling it through. So for example, if IPC guidance changed, or if there was a decrease in, there was a development with COVID that saw that it decreased, we could model that back in and get to a position with that. As I mentioned, we pulled out two main headings really that we've talked to the teams about. One was around maintaining ED performance and the really good position that we've got ourselves in around ambulance handovers and really minimal delays around that. And the other is around maintaining that elective programme. And there's some subheadings to that. Probably one I would draw out for board, I mentioned it, the board development, is we've seen a consistent pressure around emergency surgery. So we're with the new theatres, we're looking to address that through the way that we allocate those. So hopefully that'll lead to an improvement in length of stay and people's experience around that. In terms of the schemes, probably since I've been here, I've always been fairly cautious around this. So what I don't want to do is be really over ambitious, that we get a sense of a winter plan that says we're going to save all these beds and then suddenly we find ourselves that they're not quite delivering what we thought they would. So I've been deliberately cautious, but there's kind of 4 that I think we could probably push at quite hard. So Catherine's leading a big piece of work around the virtual ward. I think she's already thought of a fancy name for it and the rest of it, and she's talking to the clinical teams about that. We've seen a real success with COVID, and we were planning to do it around respiratory, but I think we're having conversations around extending that at pace with the clinicians. So we think we'll get 2 beds. Chances are we're probably going to get a lot more from that, but we've been conservative. And the other one is our ambulatory pathways. So you can see there we're working through increasing our SDEC hours. We presented some information to Audit Committee that showed the real work that's going on there in terms of admission avoidance and streaming from ED. So we want to carry on that. Surgery are doing a lot around SAU as well as an ambulatory pathway. That's really taken off. They've been running a PDSA. And we talked around, in terms of the community, the IV support out there. So we're going to push hard at that one. I've put a little bit in because I think whenever I've presented previously, I'm sorry, I could just see Anil's fingers coming at me through the screen. It was kind of a bit surreal. I've put some in there about the really good support and joint working that we've been doing with partners. So one of the things that we've recently done with social care is around some joint spot purchase for step down beds, particularly when there was a real workforce pressure in domiciliary care. And that was really appreciated, and we both worked really closely at that. So this isn't just a George Eliot plan. There are plans being developed across the system that are feeding into this. And then there's a little bit on the governance, but at that point, I'm happy to take any questions.
No, that's great, Stephen. Thank you. Craig, anything you'd like to add?
I think Stephen's covered most of it. I think the only other point I'd make is this gives us some security in terms of how we'll respond to spikes in demand, and we've seen that certainly over the last couple of months where we've had real spikes in demand, but the way the teams have then worked together to recover really quickly against that increased demand has been really good. And then just to echo the virtual ward stuff, I think is probably the key one of all of this. So expanding space without estates is really important. I think the work that we did with the COVID virtual ward and the home oximetry is the learning we can do for them rolling that out more widely with respiratory, but then frailty and cardiology. So that's probably the main focus from the acute point of view, but also partners across place.
Okay, that's great. And Craig, thank you for your hard work, as Stephen said, and please thank your colleagues. So questions and perspectives, Glenn?
Yeah, really good work, Craig and Stephen and everyone really, because actually when you talk to most other providers across the NHS at the moment, they're saying they're in a worse place than they've ever been. Actually, it feels like we're in a better place, certainly than I've seen us over the last 4 years or so. So really good work to get this together. What I really like about it is those solutions to that calculated bed problem are all about better care solutions that don't require beds, because we haven't got the staff anyway for some of those things. But actually it's better care, safer care for those patients. As you say, Stephen, I'd challenge you on the numbers, because you're being very prudent on some of these, and quite rightly so. But I think in terms of how we kind of internally performance manage this, we ought to be expecting more, particularly things like the OPAP therapy treatment. I think that will deliver more. But right to be prudent, but it's a good plan. Thank you.
I think the other thing where it's right just to recognise risk is there is a risk of us being called in to do more mutual aid to other parts of the system, which could affect our numbers. Rebecca?
Thanks, Russell. Could I just raise a bit more about the mental health pathway improvements? Because clearly that's something that we're all aware of in regards to mental health needs, not least post-COVID. And I wondered if you could say a bit more about the work going on that we're doing there, please. Thank you.
Yeah, so I think the systems recognise that there's a need for an improved mental health offer, particularly into the acute trust. So we've worked closely with our partners at CWPT around identifying those patients that come and need rapid assessment. I think the other two bits I would draw out, and you can see in the one, is around alcohol liaison nurse. So that for a while has been a pilot we've been running because we've known the teams have been telling us that that's been an issue for a while. And that's really, we signed a business case off at TMB, and what we saw there was a real evidence base around the improvements, not only on A&E, but also in terms of our gastro wards and liaison around that, and kind of home detox and the work we can do there. So we've improved that. And yeah, so I think really that's how we've kind of been tackling it. The main issue that will remain and is still a risk for the system and nationally is around inpatient beds. So if a patient needs to come in and is identified as needing a bed, there is a national shortage of mental health beds. So that experience is not optimum for those patients, but we work closely to risk assess it and manage it in the best way that we can. But I would still say that's the risk that sits there with that one.
Thank you.
Thank you, Rebecca. Thank you, Stephen. I can't see any other hands raised. So fingers crossed, carry on the great work, Craig and Stephen, and keep us briefed. We'll move on then to the improvement programme report. Jenny?
Hello. So thank you. So this is the improvement programme report. So I'll just highlight a couple of sections to pull out of the report, really. As you know, the report sets out the current status of our improvement programme across a number of workstream areas that are led by the SROs from the executive team and supported by operational colleagues in the main. A couple of things to sort of pull out specifically. Really just to say that the report this time now also includes a position statement in terms of the on page 3 of not just the SIT report, but also an at a glance sort of overview of the projects coming through the programme and the movement from month to month in the programme reporting. What we've also included is also in the report a summary of each of the key developments that have happened then in each of the workstream areas, which are listed on page 5 and 6. We have a number of projects that are on an amber status, even though generally speaking most of our projects are on track and progressing, but with each of the areas on page 6 that we've identified that where they're in an amber status, we have identified actions to take forward and mitigate that impact. We've included in the report on page 6 this time an update on Cqc, because clearly Cqc is a key part of our improvement approach, and so going forward we will include that summary as part of the reports going forward. On page 7, we've added the focus around tracking benefits realisation, and for the moment what we've done is identify where we are with our projects, identifying their measures for improvement and when we anticipate the benefit realisation dates coming forward. So going forward we'll be able to bring those benefits through, and hopefully they'll also pick up in parts of the improvement stories that you'll see coming forward as well. Finally, as you know, in the report, we always add in an improvement story, and this time the improvement story was around an estates planning piece, which isn't an end improvement story. It's identifying some work that we're doing around working with our partners at place to understand some of the estate's challenges and work together collaboratively and collectively to understand those challenges and look to utilise the opportunities of working together. HAC may wish to add something to this potentially, but as the strategic lead for estates. But the reason we focused on this as an improvement story was really the first time that a number of partners really got together to share some of the challenges around the estates piece and some of the opportunities of working more collaboratively together and really thinking about, from a place perspective, how we can bring together the understanding of our estates challenges alongside our operational colleagues about what we needed to utilise the estate more effectively and plan for that going forward. So it's a point in time with a piece of work that we're doing around estates at place, but it felt like it was an important milestone in bringing a range of people together across partners to look at some of those challenges, which we know is a particular issue for us in Warwickshire North and beyond. Happy to take any questions on the report, but those are the couple of highlights that I'd like to pull out for the standard report that you normally receive to this meeting.
Thank you, Jenny. Questions and perspectives. Anil?
Thank you, Chair. Yeah, I was just to note the progress that's being made on this project initiative. It's really good to see the progress. Can I also say that the structure and the data that Jenny, you're presenting demonstrate a good grip over the projects? I specifically like the benefits identification and benefits realization processes that you've put in place, as well as the risk management for the project. Thank you, Anil. Simone?
Thank you, Chair. Lots of work going on here. Just a suggestion, really, in terms of trying to understand the report a little better. It would be helpful to me if we could separate what's the kind of commentary on process and governance and what's the commentary on outcome and impact for patients. They're sort of all mixed in together, and it makes it quite difficult to understand where the benefits for patients are, understand the need for having an update about processes that are going on. But if we could have them as separate things, I think that would be helpful.
No, that's a helpful suggestion, Simone. Jenny, I do find it a difficult report to read, just in terms of the complexity of the sentence structure, which I don't think is me. So if once your colleagues have drafted the report, you can just do, which is always a sensible thing to do in my view, would my 15-year-old child understand what I'm saying here, test. I think we can just edit bits of the report to just make it more succinct, because clearly there is some great work going on, but the summary you give is far clearer than the report has presented. But that's not to undermine the very substantial progress that's being made. Any other comments from colleagues? Okie dokie, thank you, Jenny. So we move on then to the report on safe nursing and midwifery staffing. Darjit?
Yeah, thank you very much, Chair. So the report demonstrates that we continue to operate strong governance measures and oversight to ensure that any risk to safe staffing is mitigated. In August, we had 67 DATEX raised relating to nursing and midwifery reduced staffing, but all of those were no harm identified to patients. We also had 58 of those which were red shifts. We've seen an increase in staff using the Safe Care system, which is a much more proactive system where staff can record what staffing levels are like, and we triangulate that evidence with the DATEX, so that gives us much more oversight and how effectively we are managing the staffing issues. The matrons are also being encouraged to use this system more proactively during their huddles in the morning, so we can ensure that our data is aligned and correct. Another positive is that we have seen a reduction of staff absence for COVID-19 due to shielding, and we've had a reduction down to 87 whole-time equivalent shifts. Last month that was over 100. For our actual vacancies, Our vacancy rate for nursing associates and for registered nurses and midwives, not including Band 8A upwards, is 6.5%. Of that, 5.9% are Band 5 vacancies. But just to highlight that we have recruited into many of these posts, but staff have just not started yet. I've got something very positive to report about our registered midwives. Given the challenge nationally to recruit, we have actually over-recruited by 4%, which is a positive movement for us. In fact, we have a waiting list of midwives who would like to come and work at our maternity unit, and I think we need to thank our team for that, for giving them, you know, such a good experience as students that they want to come and work with us. In terms of our highest rates of vacancies, they continue to be on Victoria Ward and AMU, also Arbury, endoscopy and theatres, but we've got mitigations in place for those with focused recruitment days planned. For the rest of the year, we've got 3 registered nurse recruitment days planned and 2 for healthcare support workers. I'd just like to spend a bit of time on the midwifery staffing, if I may. Start by saying that we've continued to provide 100% one-to-one care and labour. And of the 41 flags that were raised, 40 of these were due to a coordinator not being supernumerary. One incident was related to a delay in induction of labour that was required to ensure that the unit was safe, but to provide assurance to the board, there were no clinical incidents associated with this. As we've seen over the last couple of months, we've seen our midwife to birth ratio decline, which didn't quite make sense to me because it didn't triangulate with the professional judgments of the senior midwifery staff and of the feel of the unit, or indeed the quality and safety metrics. So over the last couple of weeks, I've been working with the matrons to do a deep dive of our data. And what we've identified is that there's been an error which has skewed the ratio. It's a very, very small error, and it's in relation to how we calculate the sickness and put that into the calculation. Indeed, we've been doing this for some time, and it's actually the increase in sickness which has actually exposed that issue to us. So I'm able to provide assurance to the board that the recalculations which will be provided in future reports, we're just going through a quality assurance check of those, demonstrate that actually our birth rate to midwifery, midwife to birth rate ratio is actually a lot more positive than has been reported. We've put some quality assurance in place for that to ensure that there are some checks by senior midwifery staff going forward. The revised data actually shows that there was a slight increase in our midwife to birth rate ratio from around about June, but it was for 1 in 30 and 1 in 44 and 1 in 40, but it wasn't 1 in 44 and 1 in 40 as was reported. It was actually around about 1 in 30. So we'll provide the updated table. So in terms of August, our rates are slightly marginally higher. It's actually 1 in 37, but not as reported in the paper. The data wasn't available. I've only just had that at the beginning of this week. So it's to provide that assurance to the board, really. I think for August, what we have seen is a slight increase in sickness combined with a significant increase in the number of births, which has resulted in that. But the report shows that we've continued to maintain safety in our midwifery unit, and there's been no adverse outcomes as a result of that. So that's quite positive for us, I think.
Thank you.
Take any questions.
That sort of description explains some of the perplexion I think some of us had earlier. Questions and perspectives, Gertie?
Just very briefly, Chair, I wanted to give some assurance to the board because Delta has rightly picked up that recruitment has been slow, although we had a number of nurses in post. A lot of these nurses are newly qualified nurses receiving their PINs in September, and we have 17 due to start with us over the month of October, and further 2 coming through in November. So we will see some more positive increases. That is just a delay or a result of not having PIN numbers. So it's just to give the board some assurance. Thank you, Chair.
That's great, thank you, Gertie, and well done everyone involved in those recruitments. As you say, Dowd, it sort of evidences the fact that people like their experience in training. I can't see any other hands raised. Colleagues, happy to move on? So we're then on to shared services issues. Stephen?
Yeah, so what I'll do is I'll just provide a bit of context and then I'll talk through the paper and take any questions. What I've tried to do is split this over two areas really that I think are key and that board have asked previously around. So one is around the elective pathways and one is around the cancer pathways, and some of the issues there are slightly different in each, so I'll address it through that way. Really what I'm going to try and do is pull out some key points for you, the issues at kind of an organisational level for us at George Eliot that we need to own and improve on. There are some issues that sit across the two trusts that may operate within a pathway, and there are some that are system issues and are probably a consequence of the kind of COVID and the pandemic and dealing with a backlog, but also the mutual aid that's being asked of the system. So electively, we're in a really good position, but we have been asked to help other systems, particularly at UHCW and a tertiary, from a tertiary perspective, is they're providing a lot of mutual aid to other systems that are in a much worse position. So I think it's important to recognise some of these are impacted by that. The other bit we have been doing at a system level is trying to really strengthen the governance and the visibility of some of this across the three trusts. So we now have what we call the share PTL, so we can all see each other's waiting lists. So what that should improve is it doesn't just sit at George Eliot, or it doesn't just sit at Swift or UHCW and felt like it's one organisation problem, that we can now see it across all three. And what that should start to drive is some system actions to address some of this. Or if one trust is much further ahead, we can either learn the lessons in productivity or start to actually shift activity there as well, so that patients aren't disadvantaged by this. So I think that's just an important bit of context before I go through it. I think the other thing that's really important that's helped us with this is the way that the funding around ERF and the accelerator has worked for us. Because actually when I get into it, particularly around the elective pathways, that's offered us an opportunity to do something different at speed and actually start to drive some results in it in some of the areas that I think in normal working we may not have had. So we might have had this problem ticking along, and certainly for some of these areas, I think board will recall, I think there've been issues for a significant length of time and we'd never quite cracked it. So I think what the accelerator has enabled us to do is to put a different disruptive solution in, drive a result that we then say, well, how do we keep it there and not go back to what we were? So some of that is the tack that we've taken. I'll particularly draw that out into the first one then, which was around oral surgery. So this is a service that was reliant on very few clinicians and that we were building up quite a significant backlog. But between our community dental service and an insourcing option that we took, we managed to really reduce that backlog right down. And I think we'll be in a position going into winter that if we continue with it, we'll be offering mutual aid across the system, because that is one service in oral surgery that a number of areas are actually pressured in, and we've done really well at reducing that backlog. So that's something that, again, in that kind of disruptive way, we want to keep that going. Plastic surgery had done really well, but looks like, again, it's a small number of clinicians. So if anything happens to them in sort of staff shortage, pretty much like we'd seen in August, it can cause a capacity problem. So we're predicting that there, but we're working through a number of options with Swift and with UHCW about what we can do to address that. So that's on there as a risk, but we are working really intensely to try and mitigate that risk off. But we've put that service in a much better position. The one that obviously stands out from here is one that we've had to take more immediate action over is ENT. And this is one that's compounded by a number of factors. So we did have an existing SLA. There was a whole raft of infection control issues that were particularly difficult for us as a site to meet. There were staffing issues around that, but the other one was, I think there were issues in our partner where they were being asked to provide other mutual aid around other but connected services to this one. I think it's fair to say this is one that's been a concern for Trust Board for a long time, and I think it's manifesting itself that way. So what I've agreed this week is that we're going to have we're going to look at 2 insourcing options with the same company that have delivered for us. One is an outpatient one. The risk with that is, for a system, is that we'll see the outpatients, we'll clear that, but they'll then just go on to somebody else's waiting list. And from a patient perspective, that's not ideal because they'll still be waiting and there's potential for harm. The one that I'm really trying to progress with the insourcing is we'll do an end-to-end one. So we'll actually be able to treat them as well, because a lot of these treatments are day case. And I think with the new theatres, we'll probably have capacity to work through that and do some of that work. So I'll update board as we go through that, but that's the one that sits there at the minute, as you can see the risk there. And then I'll move on to the cancer pathways. Cancer pathways is slightly different, so they're shared across either from a tertiary perspective or for some of our pathways just as a partner, because we work with particularly UHCW around that. I think that's a slightly different focus, and we're doing a lot. We've got a clinically led cancer board now, and there's a lot of deep dive and work going on around it. The key for us at George Eliot, I think, improvement for these pathways is our ability to diagnose quickly and get transferred quickly, and that's the key bit for this one. So for me, that feels more in our gift to sort. We're doing some of the action around that. I think things like the Community Diagnostic Hub will help immeasurably with that, because we'll have the capacity on the site with the clinical teams to work through that really fast, and I think that will speed up that pathway naturally. There are some areas where we're asking partners and system to improve, but I have to say we tend to get a really good response from particularly the ICS cancer services. So we've now got some money for some band 7s to do some prioritisation work with us and pathway improvement. So they're the kind of chunks really that I just wanted to cover with this, and happy to take any questions.
Thank you, Stephen. Just before I invite questions, this is a very polite report, Stephen. And the issue of SLAs, just to sort of maybe for people who are less aware, and correct me if I'm wrong, SLAs are basically where we pay for a level of service from another part of the NHS for our patients to be seen as part of their pathway. We pay, as I understand it, whether we receive that level of service or not. So what we're talking about here is where to see patients in what one would regard as a reasonable time frame, a standard of service has been agreed, and then it's not being delivered. I think we need to be far more straightforward, Stephen, about which bit of the system is not delivering the service we're paying for, and effectively the taxpayer is paying for. Now, they may have mitigating reasons, which it's important for us to contextualise, but at the moment, with the greatest respect, it's too polite a report. I would not know, in reality, which bit of the system, I could guess, is not performing in the way we would expect it to. The other thing I'd just add is insourcing, for members of the public who aren't aware, correct me if I'm wrong, Stephen, is where a third party, often private provider, would say, we can use your physical assets, theatres or whatever, out of hours and provide the staff to actually do the work. So insourcing is, at one level, a great way of using existing assets which aren't being utilised. The downside is the money's going to the private sector. So again, I just want to be really transparent about what we're talking about here.
Yeah.
This is a big subject. I'd like it to come back to a board workshop, please, Stephen, because 5 minutes, which is what we've given it on the agenda, is nowhere near enough. And we've already taken 10 minutes on it. Glenn?
Yeah, it's just to further the SLA conversation, and I think this is a question for Hack rather than Stephen. During COVID, we've in effect paused SLAs and left the funding streams in place, but not held individual providers to account for non-delivery. So in the case of the ENT position, we're paying UHCW for 100% of activity, and we're getting 30% of activity. Hack, I assume I'm right that when we are then paying the private sector to recover that through insourcing, we are picking up the bill rather than UHCW. Is that right?
That's right. So we still end up paying UHCW for the service that we're not actually getting, and then we're paying the independent sector as well. And you'll see when I get onto the finance report the impact that's had on our financial position. But as you say, the SLA management is currently suspended under the COVID framework.
But we still pay the money. Let's start to highlight that far more, Hack. So when we get to your report, tell us exactly how much that's costing us, please. Julie?
Thanks, Chair. Stephen, I understand the context and the mitigation actions, and just building on what Russell has said. despite all of that and the pressure that the system is under, each delay is an individual and their families and the anxiety that that causes, and we can't forget that. I guess for me, what I need to understand in here, particularly around the areas that you've highlighted, is how patients are being prioritised, to give assurance to individuals how prioritisation is happening to prevent harm.
Yeah, so I absolutely, Julie, agree with you that it's every patient, and to be honest, that's why we've taken some of the decisions that we've taken. Is I completely agree, Russell. Insourcing is a short-term option. It's not anything that you would do. It just puts capacity on the deck really quickly. And I think that's why we've done it in some of those, because the waits are just unacceptable. We still run through a clinical prioritisation process. But what I've given you there is the raw numbers, because the problem is there and there's no point hiding it. I take the point about the polite report, but the numbers kind of do speak loudly, don't they, really? And what we've done is we've mitigated some of it off, but we've done it with short-term solutions in an environment. If this was normal working, you know, we'd be having very different conversations, I would feel. Okay, thank you. And finally, Simone.
I'd just like to support everything that's been said. They were all points that I was going to make. In addition to that, I think it's important that we see system data now alongside our own data, so that we can see very clearly what the issues are, and we should also see model hospital data and perhaps get it right first time data alongside that, so that we can see where the opportunities are for productivity improvement and what other systems are managing to achieve.
Great point. Thank you, Simone. Really good discussion. Let's bring it back to a workshop so we can do a deep dive, but thank you, Stephen. We're now running about 15 minutes late, so if colleagues can try and pick up time on their summaries. So welcome back from the photo call, David. Hope you gave the high chef a good push off on the bike when she went off. The integrated performance report, please.
Great, thanks, Chair, and apologies for being late. I am back now. So we'll start with just a general comment about the fact that our finance and performance executive meetings went ahead last week as planned. There were a number of execs who were at the workshop with UHCW and SWIFT, which I'm sure has previously been mentioned in the meeting, but the meetings went ahead despite that. So just a scoot through the integrated performance report, starting with mortality. Shimmy and HSMR are both in good shape, improving and within the expected range. That reflects the good position that's previously been reported to the board based on the improvement work that's been led by Catherine. And of course, now the challenge is for us to sustain that going forward, but that's a good, strong position to be in. From a quality indicators perspective, members of the board will have picked up from the report the fact that during August the cleaning score declined sharply, well down below the threshold. That was flagged using the SPC charts that are used to monitor this situation as a cause for concern. Rapid investigation took place. The cause of the problem was identified around high-level dusting and out-of-date curtains in a limited number of areas, and there were action by the cleaning teams to address that, and that is now being monitored to ensure that it's sustained by ward managers, matrons and the hotel services management team. In terms of infection prevention and control, good, strong MRSA screening compliance. There was one case of MRSA that had previously been reported, and that was under some scrutiny, a tabletop review and RCA. The review found that it was unavoidable, but there were several lessons learned as a result of that review, which are now being implemented. No cases of C. diff to report for the reporting period. Falls remained below the threshold of falls per 1,000 bed days. We had one fall with moderate or severe harm. Again, a tabletop review took place with the root cause analysis and lessons learned communicated out into clinical teams across the organisation. No issues from a pressure area care point of view, with no avoidable ulcers graded 2 or above. And friends and family test reporting a strong majority of patients declaring that their experience with the hospital was good or very good. In terms of operational performance, in line with a pattern that's evident across the country. A&E attendance is showing a general upward trend, although in August that was slightly lower than expected, and attendances to the department was slightly lower than expected. Some quite significant pressure across the hospital during the August reporting period, resulting in our performance dipping below the kind of internal target that we've set for ourselves, and penciling out at 86.5%. So a drift from the national targets, but still better than the region and national mean, and actually in terms of league table performance when compared to other organisations, still pretty good. We only had 3 ambulances delayed more than an hour for offload. The team in the department are now root cause analysing every ambulance delay over an hour. There was no harm from those events, but significant learning again implemented in the department as a result. And our performance notable as a positive outlier against many other organisations across the region and nationally, and that was positively commented upon in the Coventry and Warwickshire System quarterly performance review with NHS Improvement in England a few weeks ago. I think Glenn was in the room for that conversation. Elective activity, so planned care activity at 109% of the 1920 baseline, despite those operational pressures that I've described and some significant challenges with staffing across the organisation as a result of increased staff absence and isolation and so on. We'll come to that in a second. The Coventry and Warwickshire System as a whole against the accelerator target is performing very strongly, and again positive feedback in the quarterly performance review about the system and individual organisations within the system's performance against those targets. Outpatient capacity remains the biggest challenge around social distancing and volumes of patients that can pass through our respective clinics, and we're currently reassessing the situation against new national guidance around that, and also just looking at the way that that's measured, and there are certainly national discussions about all of this taking place in terms of the way that we look at this in the future. Having said all of that, RTT is improving steadily. We've got 473 patients who are greater than 52 weeks and a plan to reduce that continuously going forward. And we've got an aim to get to no patients greater than 104 weeks by, well, it says in the paperwork December, but we've discussed this morning, and I think November is where we're aiming for. So we're trying to bring the threshold for that forward, because 2 years is an awful long time to wait for an operation. So we'll get on top of that. Diagnostics, so again, slightly adrift of the target. Very clearly understand that the reason for that is reduced radiology capacity, particularly relating to MRI and ultrasound, and there's a plan in place to address that. But again, comparatively, we're still in reasonably good shape compared to other organisations across the country. Cancer, clearly, we've just had a conversation about cancer pathways in the previous item, and the system is clearly providing mutual aid outside of Coventry and Warwickshire. That's impacting on some of the pathways that are being managed internally, and Stephen and the team working very hard to deal with that with partner agencies from across the piece. And in terms of 104 days, that number has gone up a little bit this month, so it's double what it was in previous months, with 8 patients waiting more than 104 days for treatment. And we are working very hard to case manage those people through their pathways. A positive point relating to cancer: in July, our 2-week weighed breast pathway was 100% compliant against the standard. We're the only trust in the country to deliver that, and as a result, we're the best in the country in performance against that particular element. Stroke continues to be an area of focus, and flow across the hospital is a challenge with regard to this, particularly with the speed of COVID result availability to allow us to place patients appropriately. So we're looking at how we introduce more rapid testing into the system to be able to deal with that, and we'll be able to update about that at the next board meeting. And then finally, from a people perspective, absence continues to be higher than the expected seasonal average at about 5.2, 5.3%, and that continues to be a challenge for us as we run the hospital on a day-to-day basis. So that's a whistle-stop tour of our IPR, and I and colleagues would be happy to pick up any questions.
No, that's great. David. Really comprehensive, and some real signs of encouragement in terms of performance. So congratulations to you and the executive directors. Any questions or perspectives to David? Stand us all in silence, David. Well done, team. Keep that elective performance driving hard, and let's get the cancer pathways sorted as well. So we'll move on then to the finance report. Hack.
Thank you. We've got a deficit of £1 million after 5 months, and we're forecasting a deficit of £1.3 million at the end of the first half of the financial year. That forecast deficit is entirely due to the change in the ERF threshold that kicked in from the 1st of July. In terms of looking at the broader picture, the last few months have been difficult in terms of recovery activity due to the bed pressures and availability of staffing. But having said that, we've done relatively well as a system in terms of our recovery performance, but it still means that we've earned very little elective recovery funding in August, and we don't expect to earn a material figure in September. But what we have done is continue to treat as many patients as we possibly can under those difficult circumstances. So we have incurred additional expenditure in treating those patients, but we haven't then recovered that through the elective recovery fund. That means that accounts to a loss of nearly £1 million. We've spent about just under £3 million on that additional activity, and we're expecting to earn just under £2 million of elective recovery funding. So going back to the earlier discussion, some of that loss is related to the fact that we're having to insource activity that should be provided by the SLA, but it's not entirely due to that. So what I'll do for next time is draw that out more clearly in the report in terms of the additional cost we've incurred compensating for the under delivery against the SLAs, and make that really clear going forwards. We can mitigate that £1 million impact there largely through vacancies and delays in recruitment against the business cases, hence why it's not impacting our bottom line over and above the threshold impact. In terms of our efficiencies, we had a target of £2.9 million for the first half of the financial year, and we expect to deliver all of that. Having said that, some of that is being delivered non-recurrently. We have got plans in train to deliver that recurrently, but those have been delayed because of some of the operational pressures, but I'm expecting those to pick back up again for the second half of the year. So I'm not expecting that to cause a problem for the second half of the year in terms of currently delivering our savings plans. So looking forwards, a key focus of the second half of the year is going to be on that CPIP delivery, and the key elements of that are going to be reducing, continuing to reduce our agency spend and improving productivity. I'll leave it there and take any questions.
That's great, thank you, Hack. Any questions or perspectives to Hack? Glenn.
Obviously, Hack, the planning guidance for the second half of the year has only just landed, so we're working our way through that. But my assumption is that gives us a bit more flexibility on the CPIP targets for the second half of the year than we thought. Is that right?
In the planning guidance, what they've said in terms of the CPIP target is what we expected. They had kind of released some of that information, but it's a better settlement than we originally thought. But in terms of the plans that we're working up at the moment, the 0.82% efficiency target for the second half of the year is what we expected.
I guess the principle should be we should drive cost and productivity improvement as hard as possible out with the funding settlement. And any other questions to Hack? So in summary, Hack, we're losing about £1 million and a bit. We wouldn't be losing £1 million and a bit if we'd been paid the money we were told we were going to be paid at the start of the year, but such is life. Colleagues, happy to move on? So move on then to the capital progress report. Again, back with you, Hack.
Thank you. I'll just draw out some of the key points from the report. So we'll start off with a really good news story. We've got funding agreed for phase 1 of the community diagnostic hub. So that's £2.7 million, which adds to the £800,000 that we'd already agreed to put towards that. So that takes our overall capital programme for the year to £9.35 million. The other key message is that we've only spent we've spent less than 20% of the original £6.6 million plan as at the end of August. That's not particularly unusual based on previous years, and it's also in line with where our ICS partners are, and also the regional picture is also very, very similar to that. Ordinarily, it's not an issue, but there are some significant risks. I think this year, some greater risks than we'd normally have around supply chain issues, which are likely to impact some of the major building works, and significant price inflation as well. And we have got some fairly large building programs in train at the moment, and we're also bidding for some additional funding as well. So there could be more to come. So what we're doing are reviewing the projects with relevant leads. We've reviewed most of them at the time of writing of the report, and almost everyone is saying that they will deliver their projects. So we are tracking those in more detail than previously. We put some additional processes in place to make sure we are monitoring those really closely. But I'm flagging two risks at the moment. One is around the air handling units and ductwork replacement, and that's largely around logistics of being able to carry out the works and getting access to the areas that we need to, but also around the process of tendering and supply chain issues. And the second project we have a risk with is around the wellbeing hub. At the moment, we don't have an agreed solution for that, and the latest design involves building an extension, which and that exceeds the available budget. So we're reworking that one at the moment. At the time of writing, we'd only just heard about the Community Diagnostic Hub funding, but at the moment there is a risk that will slip as well. But I'm planning on managing that in the same way that we manage the theatres funding between the 2 years, i.e. moving our own funding in between the 2 years. So I'm less concerned about being able to manage that, but it's the accumulation of some of these risks that I'm slightly concerned about. So in short, there's a significant risk of slippage, which is countered by a significant risk of inflation. And as I say, we have put in place additional controls and working very closely with our system partners as well to make sure that we manage the risk collectively, because they're facing very similar risks to the ones that we've got as well. And the final message was around some changes to the capital programme. So Trust Management Board have approved a virement of 50k from the ward refurbishment budget to feasibility work on the ambulance station and the maternity blocks, and that's because we just weren't going to be able to spend the money on the ward refurbishment because of the pressures. We haven't been able to access the wards, but we recognise we still need to do some work on the bathroom, so we've still spent £150,000 on upgrading the bathrooms on the wards. So I'll take any questions.
That's the expensive bathrooms. Questions or perspectives to Hack?
Lots of bathrooms.
Thanks. Sorry, Russell, was that okay? Hack, you've clearly set out the risks and the additional monitoring that's taking place. I just wondered if you could give some assurance around those risks, not only in terms of financial slippage, but if there are risks to operational performance or health and safety matters.
Yeah, so part of the whole process of managing is managing the risks as well as the finances. When the capital management group reviews these projects, they're looking at the risks that we'd have if we weren't able to complete these projects to the original timescales, and making sure mitigations are in place to manage those risks.
Thank you, Julie. And any other questions to Hack? Keep us briefed on the capital, Hack. Thank you. I think inflation is definitely going to be hitting us quite hard on all capital projects going forward. And the summary of ratified policies. David, anything you particularly wanted to put out?
Thanks, Russell. So I'll take the paper as read. It's a statement of policies that have been through the committee, and other than that, if anyone's got any questions, happy to take them.
Okay, great. Any questions to David on the ratified policies? Can't see any raised digital hands, so we'll move on then to the board assurance framework and the high and extreme risks. David and Sarah?
Yes, thanks. Sarah, would you like to talk to this?
Yeah, great. Thanks, David. So this is the Q2 BAF, which has been through the governance review process for challenge and scrutiny and submitted to the board for information. A Attached to Appendix B is a proposed new template for presenting the BAF risks, which will make it a consistent template across the foundation group. So it's submitted to the board to approve for using the template from Q3 onwards. So happy to take any questions.
Thank you, sir. So if we talk first of all on the substance of the current BAF, any questions on that? Julie?
Yeah, thanks, Chair. I was just, in terms of the higher risks and comparing that to target, we're a long way off in a number of the high risk compared to target. And I wondered if there was, at the next exec group, if we could actually look at whether those targets are realistic and in what time scale, because there is still a lot to do to reach those targets.
No, good point. Thank you for that, Julie. And any other questions on the current BAF? So the proposal is, in terms of the way we present the BAF, that we adjust to a foundation group common approach. Any questions on that proposal? Glenn?
Yeah, just to clarify that, I mean, we don't have to use the same template. It's just that we found it works better in the other parts of the group rather than it being something we're just doing for the sake of it.
Okay, so if you're not happy to agree with the proposal to move to this new approach, please raise a digital hand. Okay, uniformly agreed. Thank you, Sarah, and thank you for your work on that.
Thank you.
Move to the annual review of policy review group terms of reference. David.
Yeah, thanks, Russell. So again, I'll take the paper as read, and essentially we've just undertaken the annual review of the policy review group terms of reference. The terms of reference are presented there. There's a minor change, a couple of minor changes, one of which is actually the review date for next year. So unless anybody's got any questions, happy to move through that.
Okay, any questions from colleagues? Okay, everyone happy to approve that? Thank you. Then we've got the annual review of, the review of finance and performance exec meetings and the approach. Glenn and David.
Yeah, Glenn, are you happy if I kick off and
more than happy, David.
More than happy, excellent. So I'm sure members of the board will recall that we undertook a review of our approach to finance and performance executive meetings at the Trust. And once we completed that, we then went on to undertake a comparative piece of work across the group, which we subsequently presented to the Foundation Group Strategy Subcommittee on the 31st of August. And the outcome of that conversation was that we come back to our respective boards in our organisation and ask that they support the recommendations that are set out in the paper. So there's 10 recommendations, and the recommendation from the Foundation Group Strategy Subcommittee was that we support those recommendations and get on and implement them. So this paper is bringing that to our board meeting for discussion and agreement of that approach.
Okay, Glenn, anything you want to add? Yeah,
if I may, in our confidential meeting today, there's a paper which looks at a review of the Foundation Group arrangements. That will come back into public board next month, but it does incorporate this recommendation if it's approved.
Great, thank you, Glenn. Any questions or perspectives from colleagues? Julie, anything you want to add as the Foundation Group rep from George Elliott?
No, nothing else to add at this point.
So if you're not happy to approve this change, please raise a digital hand. Okay, let's go forward, guys. Thank you very much.
Thank you.
So we then move on to the subcommittee chairs updates. And the first is the Quality Assurance Committee of the 23rd of August, and then the update from September. Rebecca, thank you for standing in for Glynis. Over to you.
Thanks, Russell. So in regards to the update of our recent meeting, QAC considered a broad range of areas, including the people report, nursing and midwifery quality, the improvement work of the medication safety and optimisation committee. So a really positive meeting. 4 areas to quickly highlight. Cqc recognised the vigilance applied in monitoring the birth to midwife ratio, including particularly evidence-informed contributory factors and mitigations to ensure safety and quality of care. We also reviewed the revised quality and equality impact assessment process, and we recommend to board the approval of the Trust's revised quality, equality and impact assessment policy, which is not only clear and proportionate, it also emphasises, in the committee's view, our ongoing commitment to inclusive practice in all we do, including the way that we do our business. Cqc was also encouraged to receive an impressive research and development annual report, and we should really note the exemplary profile and contribution of this team, particularly for an NHS trust of this size, including involvement in 11 urgent public health studies linked with COVID, which has directly benefited patient treatment, and several national trials. We commended the team on their exceptional success with patient recruitment, with over 1,500 patients recruited, which was double the previous year. They've attracted additional funding on the basis of their performance and also implemented rapid changes to team working. And then finally, Cqc took positive assurance from the extensive programme of work which Stephen's already mentioned in cancer care, and in particular in lieu of the most recent National Cancer Patient Survey. A key area amongst several service priorities was a focus on patient engagement and monitoring responsiveness to early diagnosis. The risks to this specialist workforce were particularly noted, though. Happy to take any observations or questions. Thank you.
Thank you very much, Rebecca. Any questions or perspectives to Rebecca? Some really encouraging stuff coming through, I think, in summary, Rebecca. Okay, no, thank you very much for your hard work, and please thank Glynis and everyone else involved as well. Thank you. So then move on to the Audit Committee of the 28th of September. Julie?
Thanks very much, Chair. In the interest of time, I'll assume read. It was a very robust discussion, as it always is at Audit Committee. There were a couple of areas where we've asked for an update before the next committee, as we don't meet monthly, we meet bi-monthly, particularly discussion around the DSPT improvement plan and risks around actually delivering that, but also the EBME internal audit report. Just for board to note that the focus of our next audit committee meeting will be around a revised EBME internal audit report, following some additional work being done there, and the business case reviews for pharmacy outpatients and closure of the aseptic unit. And like to give some assurance around the fact that Audit Committee are continuing their focus on pharmacy stock losses. Thanks very much. Take any questions.
Thank you, Julie. Any questions or perspectives to Julie? Okie dokie. Thank you for your hard work on that. And just continuing that vein, the Foundation Group Strategy Subcommittee of the 31st of August.
Yeah, again, Russell, very good discussion there. We continue have the focus on areas of collaborative working, and some of the areas are set out within that note. Just to bring to the attention the improvement of communications within the group, but also an individual trust level. And other than that, didn't want to actually highlight any other points at this point.
That's great, thank you. Any questions to Julie on the Foundation Group strategy work? Okay, then we've just got a couple of reports which are in the pack for completeness, about the Cqc of the 23rd of August and the Audit Committee of the 27th of July, which we've discussed previously. Any other business, colleagues? If you've got any other business, could you please raise a digital hand? Can't see any digital hands. So any questions from members of the public? Sarah, have you been made aware of any?
We've just had one from Councillor Condacor. With regards to the Integrated Performance Report, it includes 2 COVID deaths in July, and that they were believed to be community-acquired COVID cases. Can you give the figure for August and September COVID deaths with a breakdown of how many community cases or possible hospital cases, and Catherine's going to answer this one.
Okay, thank you for the question, Keith. Catherine?
Yes, Keith, the answer to your question is that in August there were 6 deaths from COVID reported by the Trust, and in September there were 9 deaths. All of those were community acquired cases.
Okay, thank you, Catherine. Any other questions from members of the public? Please raise a digital hand. Natalie. Natalie, if you're talking, I can't hear you.
Hi, can you hear me now?
Yes, you're a little quiet, but far away. Okay, Natalie, I can't hear you. Could I just ask you, maybe put the question into the chat box, and then I'll make sure it's asked. Keith, you've raised your hand?
Yeah, thank you for that answer. It's great there aren't any actually in the hospital, but I think it's useful for these reports every month to have the figures in. I hate cherry picking. So if you say 2's obviously better than 9 or whatever, and I hope it's actually 0 this month. Obviously, I'm trying very hard for that to happen. One question I did have is cancellations of operations on the day. I know someone who had their operation cancelled for this week, not actually at this hospital. But obviously they were seeing the consultant at this hospital and having an operation elsewhere. Is this something that's happening a lot, and why are we still cancelling on the day? Thank you.
Okay, thank you, Keith. Stephen, do you want to answer that one, please?
Yeah, so fortunately it's a rare event. It does happen. It tends to happen around particular staff shortage if it does happen. So if there's a surgeon that can carry out a procedure, if we can't cover it, that's the way that we'd cancel it. But we do talk that through with the directorates, and I'm happy offline, Keith, to have a conversation. I'll drop you some figures for us so you know what the position is for the trust. Okay, I think just generally though, Stephen, if you take a typical week in the last month, a typical week, how many cancelled operations would we have in a typical week? God, that's asking me. Cancelled on the day would be less than 1 or 2 lists in the month. Okay. So in a month, we'd maybe see 5 to 10 operations in a month cancelled on the day. Yeah, around that, depending on the list. Yeah. Okay, so that contextualises things a bit. Glenn, your hand's up.
Yeah, I was just picking up on the general mortality point. Actually, we skipped over this a little bit actually early on in the meeting, but it's quite a significant position that the trust has moved into on its overall mortality based on the national benchmarks that we're now well in the as expected range and around the 100 mark on the shimmy, which is a significant improvement on where we were before. Obviously, there will continue to be COVID-related mortality throughout this winter across the NHS, but as Keith suggests, we need to make sure that that those are community-acquired cases, not hospital-acquired.
Yeah, and Catherine?
Yes, and I'd just like to get my monthly public health message out there. The importance of vaccination about protecting people from serious illness and death is so important. And particularly important at the moment whilst there's people being invited for boosters. So whether, particularly if it's your first and second vaccinations, please go and get those, but your boosters are also important. So that's the public health message for October.
Thank you, Catherine. And Natalie, I can't see a question appearing in the chat box, so maybe you're having a problem putting it into the chat box. But if you want to email me with any question, please do so. I can't see any other raised hands, but thank you everyone for attending. Look forward to seeing you at next month's meeting. And in the meantime, everyone take care. For members of the board, we'll get the confidential board going at 3:30 just to save some time. Thank you very much. Bye-bye.